Good afternoon. I'm John Iskander. Welcome to the October 2014 CDC Public Health Grand Rounds. A special welcome to those joining us from outside of CDC and to those watching not live but later from their houses, offices, and schools. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, of course, health educators, and others. All of this information is available on the Grand Rounds website, which is cdc.gov/CDC Grand Rounds. Grand Rounds is available on the web and multiple social media sites. We have a featured video segment on YouTube called Beyond the Data, which is posted shortly after the session. A little bird told me to tell you this. Sorry, couldn't resist. Please use hashtag CDC Grand Rounds for all your tweeting needs. Public Health Grand Rounds is happy to participate in recognizing American Pharmacists Month. Please contact the American Pharmacist Association website for more information. In addition to today's outstanding featured speakers, who I'd like to thank for their important and ongoing work, I'd also like to acknowledge the important contributions of the individuals listed here, many of whom are members of the CDC Pharmacists Workgroup. We've partnered with the CDC Public Health Library and Information Center to feature scientific articles relevant to this session. The full listing is available at cdc.gov/scienceclips. Here's a preview of upcoming Grand Round sessions. Please join us live or on the web at your convenience. And for some introductory remarks, I would now like to introduce CDC's Principal Deputy Director, Dr. Ileana Arias.
Thank you, and good afternoon. As many of us know, chronic diseases such as heart disease and diabetes are the nation's leading causes of death, disability, and poor health. 1/2 of Americans have at least one chronic condition, and 1 in 4 have multiple chronic conditions. The U.S. spends approximately $2 trillion, that's almost 85% of its healthcare expenditures, on chronic disease treatment and management. Over the past decade, prescription drug use in the U.S. has increased steadily, and it's expected to continue to grow. Data from 2006, which is the year that we have the most recent data available, indicate that 1/2 of Americans take at least one prescription medication, and this is even more pronounced when we look at older adults. 9 out of 10 older adults have used at least one prescription drug in the past month. 2/3 of adults over the age of 65 take anywhere from 5 to 9 medications, and almost 1/4 take 10 or more medications, and most of these are used to treat chronic disease. Today we're focusing on the critical but often overlooked link between public health and pharmacy that can contribute significantly to health outcomes in several public health priority areas for our country. For example, data have consistently shown that pharmacist-delivered drug therapy monitoring, counseling, and educational services contribute to improved health outcomes for chronic conditions such as hypertension, diabetes, and hyperlipidemia. CDC has identified inclusion of pharmacists as a core element of antibiotic stewardship programs across U.S. hospitals to combat antimicrobial resistance. And CDC is also pioneering successful strategies to expand access to HIV testing to retail pharmacies. The healthcare system is in a time of transformation. The Affordable Care Act will increase access to healthcare for approximately 34 million Americans. It's a critical time for us to focus our strategies on improving healthcare outcomes and reducing unnecessary costs. Pharmacists are extremely well poised to help address the growing burden of chronic disease and to improve access to quality care. There are over 60,000 pharmacies in the U.S., with 93% of Americans living within 5 miles of a retail pharmacy. For years, pharmacists have consistently been identified by patients as among the most trusted healthcare providers. For chronic diseases such as hypertension and diabetes that threaten to overwhelm our healthcare system, we now have almost a decade's worth of data demonstrating that when pharmacists are integrated into the patient's healthcare team, they can reduce fragmentation of care, lower healthcare costs, and improve health outcomes. As key, trusted, and accessible healthcare professionals, pharmacists in expanded roles can have a positive impact on the healthcare system and on patient health in numerous ways. So, for example, they can improve access to preventive services and effectively and safely deliver care in areas like immunizations, tobacco cessation, and cardiovascular reduction. Let's not forget that about 20% of U.S. adults, including my husband and our 2 children, get their annual flu shots at a pharmacy or retail store. Pharmacists can improve medication adherence and contribute to improving health outcomes such as enhanced blood pressure control and fewer emergency department visits and hospitalizations. And importantly, they can also play a very important role in preventing harm from medications by counseling patients on the potential for misuse and abuse, and using prescription drug monitoring programs to alert prescriber to cases of excessive use or abuse and potentially dangerous drug combinations. In fact, pharmacists are at the front lines of the prescription drug overdose epidemic in this country and vital to our efforts to reduce misuse and abuse while safeguarding legitimate access to treatment. Today, we'll hear about important strategies that pharmacists have at their disposal to make a difference in population health. It's imperative that we identify and integrate these strategies at the national, state, and local levels into patient care. This means linking our public health programs to pharmacy patient care services that have demonstrated positive outcomes in areas like blood pressure reductions, diabetes and cholesterol control, medication adherence, and medication safety. Also identifying new, innovative ways that pharmacy patient care services can support the public's health, and allowing pharmacists to practice at the top of their license as part of the healthcare team. As our population ages, the growing complexity and burden of chronic diseases demands that we identify new strategies to pay for quality care, to improve outcomes, and to control costs. We all look forward to seeing our nation's physicians, nurses, pharmacists, and allied health professionals working together to achieve these very important goals. Thank you.
Thank you, Dr. Arias. Our first speaker will be Commander Michael Lee.
Thank you, Captain Iskander, and thank you, CDC and the Public Health Grand Rounds team for providing us the opportunity to come here and speak today. Today, you will hear about how pharmacists can serve a key role in improving public health and healthcare, and share with you some of the evidence to support this. Our U.S. healthcare system is in a time of transformation. We look at government as well as private groups across the country have been developing new models of care based upon current as well as projected needs. You look at the medical home model in which we are transitioning our care plan to. You look at the team-based approach that was previously mentioned as we're practicing to the fullest of our licensure. You look at government programs such as the Partnership for Patients, such as Healthy People 2020. And why? Why is this? At the key point for each of these is access to care and improvements in quality of care. Those are the keys. Our U.S. healthcare system is at a tipping point where people have expressed concern about access to care as well as quality care. Additionally, as was previously mentioned, healthcare costs are at alarming rates. They are increasing on a daily basis. From a medication standpoint, medication adherence as well as medication safety are at a tipping point. You see, both greater adherence to medications by patients as well as safer use of medications can improve the quality and lower costs, and our pharmacists, are in a key position to affect these change in the communities and our healthcare setting. Data from the Association of the American Medical Colleges indicate that as our population ages, the supply of physicians in the U.S. is being outstripped by the demand. It is anticipated that by the year 2020, we will need between 52 to 91,000 new physicians. Expand that out to 2025, 131,000 new physicians. Access to health care insurance has increased recently following the passage of the Affordable Care Act. That's increased eligibility for health care insurers into our system. In 2012, according to the CDC, the Center for Medicare and Medicaid Services, the U.S. has spent more than $2.8 trillion in U.S. healthcare expenditures. Approximately $1.7 trillion in that U.S. healthcare dollar has been attributed to chronic disease. That's 60 cents out of every healthcare dollar attributed to managing chronic conditions. Our population is aging. 2011 CDC data showed that our life expectancy has increased to nearly 79 years of age. And by the 2030, it's, according to the Census Bureau, 1 in 5 Americans will be over the age 65. Chronic condition, chronic disease, is the leading cause of death and disability among Americans. Half of our American population have more than one chronic condition, and 1 in 4 have multiple chronic conditions. When you look at spending, 99% of Medicare spending is related to chronic conditions. 81% of our hospitalizations are accounted for by patients with chronic disease. With our population living longer but experiencing greater morbidity, prescription medication use has risen. Our aging population is using more medications more frequently. 9 out of 10 older Americans take 1 or more medications. 2/3 of our Americans greater than the age of 65 take between 5 and 9. You see, medications are one of the foundational pieces in managing chronic disease. Patients with chronic conditions account for 91% of all prescriptions that are filled in our pharmacies across the country. Because medications are and do comprise such a large component of our medical treatment, problems with their use hamper optimal patient care, especially for individuals with chronic disease. And they are costly to all of us, above and beyond just the cost of the medication alone. Problems with medication use has been shown to be common and vary from medications not being obtained in the first place to medications being taken at the wrong time, at the wrong dose, or other unintended ways. You see, 20 to 30% of prescriptions are never filled in our pharmacies. 50% of prescribed medications are not being taken appropriately. And they are major contributors to excess healthcare utilization. So given the importance of using medications effectively and as a way to effectively improve healthcare quality as well as lower costs, it should follow that our pharmacists can be major players in helping to improve access to health in communities nationwide. You'll see today that besides making intuitive sense, this claim is backed by a substantial amount of evidence from real-world settings. Pharmacists are very accessible healthcare providers. There's nearly 275 million visits to a pharmacy each week. That is real access. Pharmacists are well poised to provide a number of additional services beyond just the use of medications in the primary as well as secondary prevention. Accessible preventative services, as was previously mentioned, immunizations. And while this list is not fully inclusive, I wanted to represent just a few of these. Right now, we are thinking about the influenza season and getting our flu shots out, and pharmacists are well poised in giving flu shots every day. Pharmacists provide cardiovascular risk reduction clinics. Pharmacists provide tobacco cessation, are very active players in providing tobacco cessation education in our clinics. Disease screenings as well. Pharmacists are also heavily involved in disease state management through patient education encounters, through care team involvement, as well as case management and providing the direct follow-up care. Additionally, pharmacists are involved in disease management and provide additional access to patients with multiple diseases. And again, I list just a few of those here. Historically, these were born out of physician shortages. However, we're moving those models from replacement of physicians into a model of, again, playing our expert role alongside our teammates with our physician, PAs, nurse practitioners, and others. Our pharmacists are involved with diabetes management, cardiovascular disease, pulmonary disease. And while today's primary focus has been around chronic disease, our pharmacists do play and are participating in the care of infectious disease, most notably HIV as well as hepatitis C. And our pharmacists are doing great and providing great outcomes in those areas. With pharmacies serving as healthcare leaders and leaders in adherence programs with medication adherence, we've seen that patients are more satisfied with their care, can take better, utilize their medications better, lower their blood pressure, as well as have fewer emergency department visits. One example of some disease state management comes from the facility in which I practice. We have a heart failure management program in addition to a number of other clinical services there in Claremore, Oklahoma. Much like many of the other clinical programs, this was developed as based upon a need. It was based as a transition of care model. That need was heart failure was a common diagnosis in the healthcare setting in which I practice. Patients with heart failure are also frequent users of the emergency department, and it was a frequent cause for readmission. Our pharmacists become involved in the care of that patient while the patient is hospitalized in the hospitalization. Our pharmacists come in and educate patients directly at the bedside and provide care during that hospitalization. Additionally, that care is transitioned to the outpatient setting as we follow the patient and provide post-discharge care as well. What we've seen with that program is a reduction in hospitalization, a reduction in readmissions, a reduction in emergency department use, as well as increased utilization of those medications, and most notably known to improve the care of our patients with heart failure and appropriately utilize those medications. So as you will hear from my colleagues today, optimal use of pharmacists in today's healthcare landscape is a key intervention that can increase the quality of healthcare in both measurable and reproducible ways. It does more than earn its keep based upon the economic analyses, with up to $12 in healthcare savings for every dollar that's invested in pharmacy programs. I want to take a moment to recognize Admiral Scott Giberson as well as Captain Sherry Yoder. I was privileged to work alongside these two as one of the co-authors of the 2011 report to the U.S. Surgeon General. This document summarized the evidence supporting the cause for pharmacists in expanded roles and showed that pharmacists providing these roles is both cost-effective and improves outcomes. It's an excellent source for additional information that I would certainly refer you to. Again, thank you, CDC, for this opportunity, and now I'd like to take this time to introduce our next speaker, Ms. Ann Burns.
Thank you, Commander Lee, and thank you to the CDC for this opportunity. Today I will provide an overview of pharmacist patient care services and highlight how pharmacists are a solution to addressing patients' unmet healthcare needs. The pharmacy profession moved to an all-doctor of pharmacy or PharmD degree in 2002, when training increased from a 5-year program to a minimum of 6 years. Pharmacists train extensively on the clinical applications of medications in the treatment and prevention of disease. Graduates serve as a source of comprehensive medication information for patients, physicians, and other healthcare practitioners. Pharmacists are licensed by state boards of pharmacy, and they must pass a national exam and meet the law and experiential requirements in their state of licensure. Various postgraduate training opportunities exist for pharmacists to further their clinical skills. Pharmacists use a patient-centered collaborative care process to deliver a variety of patient care services. Their medication-related training positions them well and has resulted in increased expansion and uptake of medication management and medication reconciliation services, as well as those focused on preventive care and disease management. Medication management is at the heart of pharmacist training and encompasses a spectrum of services that are focused on optimizing medication use and enhancing patient safety. Services are tailored to the individual needs of patients, and they should be coordinated with the patient's other healthcare services. Patients may receive medication-related services that focus solely on medications, like a medication review for a complex patient on 15 medications, seeing 4 different physicians, or medication management may be a component of disease management programs, such as for diabetes or congestive heart failure. Medication reconciliation that includes an assessment of medications is considered to be a medication management service. There is currently wide marketplace variability in the terminology and also the service design used for medication management services. To facilitate consistent delivery, a patient-centered MTM service model outlines 5 core elements shown here in red. The foundation of this model is the medication review, and in a comprehensive medication review, or CMR, the pharmacist assesses all of a patient's medications, including prescription, non-prescription, herbal supplements, for safety, effectiveness, appropriateness, and adherence. From this review, the pharmacist creates a care plan and then works collaboratively to address identified problems. Outputs of a CMR are a reconciled medication list and a patient-specific action plan that the patient uses to self-manage their medications. Intervention, referral, documentation, and follow-up are all integral parts of this service model. Additional CMRs or targeted follow-up reviews are conducted to achieve desired outcomes. The Medicare Part D Medication Therapy Management, or MTM program, has been in place since 2006. CMS contracts with prescription drug plans to administer this benefit to targeted beneficiaries. Each plan creates its own eligibility criteria from 3 required parameters: a minimum number of medications, minimum number of chronic conditions, and a predetermined annual drug spend. Differences between plans can mean that a Medicare beneficiary may be eligible for MTM in one plan, but not another. MTM beneficiaries are eligible to receive an annual CMR, a personal medication record, a medication action plan, and quarterly follow-up monitoring. In addition to Medicare Part D, coverage of pharmacist medication management services is emerging in state Medicaid programs such as Minnesota, Iowa, and Ohio, private sector health plans, often as part of diabetes management programs like Diabetes, and new health delivery models like patient-centered medical homes and accountable care organizations. Collaborative care models are emerging where healthcare providers use a team-based approach to coordinate care and improve health outcomes. Pharmacists in both outpatient and inpatient settings contribute medication expertise and also skills in disease management and prevention as members of the healthcare team. As authorized by state law, pharmacists can enter into more formal collaborative practice agreements, or CPAs, with providers that permit pharmacists to perform patient care functions beyond their normal scope of practice. The terminology used for these agreements can vary from state to state. There's also state-to-state variability in the services that pharmacists can perform under CPAs. The services often include initiating, modifying, or discontinuing medications and ordering laboratory tests to monitor medications or the diseases associated with them. Treatment algorithms may be a component of CPAs. CPAs provide the pharmacist with advance permission to perform certain delegated functions, such as adjusting a medication dose, that they would normally need to seek permission from the provider for, and then make that adjustment later. The federal sector has a strong history of leadership in the use of CPAs. This map, created from 2014 National Alliance of State Pharmacy Associations data, shows the current collaborative practice authority laws in the U.S. Currently, 48 states have some form of collaborative authority. The states shown in green have broad authority, where the states shown in yellow have restrictions in place, such as by practice setting, or by type of drug, or by chronic condition, or by having the agreement be for just a single patient versus a physician's population of patients. Pharmacists in the 2 states in red do not currently have authority. There are many benefits of CPAs. Patients have improved access to care through expanded primary care services that are delegated to pharmacists by providers. The agreement, if well constructed, can reduce administrative burdens on providers by empowering pharmacists to provide care that is facilitated by the agreement, yet keeps the provider informed of the pharmacist's activities. CPAs also foster collaborative relationships that enhance coordination of care. This slide highlights some examples of key preventive services provided by pharmacists. In all 50 states, pharmacists are authorized to provide immunizations, although the type of vaccine allowed and the patient population can vary by state. As stated earlier, nearly 1 in 4 patients received a vaccination in a community pharmacy in the past year, and it's estimated that 18 to 24% of patients receives their flu shot from a pharmacist. Health screening services such as for cholesterol, A1C, bone density, and depression are offered in the community to help identify patients who may need treatment. Pharmacists educate these patients and can also refer them to see a provider if a diagnosis is needed. Counseling and education services in areas such as smoking cessation and lifestyle modifications are also offered by pharmacists. There's extensive evidence that demonstrates the value of pharmacist services. A recent review performed by Avalere Health found that pharmacist medication management, education, and behavioral counseling, and inclusion of pharmacists in collaborative care models has been shown to improve medication adherence and also clinical outcomes for patients with chronic conditions such as diabetes, cardiovascular disease, and hypertension. Medication reconciliation can detect and reduce medication discrepancies and also reduce adverse drug events. Pharmacists are effective in delivering immunizations and may be able to increase vaccination rates, particularly for certain populations and vaccines. And given their community presence, pharmacist screening services can serve as a platform for public health initiatives. A recent systematic review of the Part D MTM program found that adherence and quality of prescribing were improved through medication therapy management, especially with comprehensive medication reviews. As an accessible healthcare provider with expertise in the appropriate use of medications, pharmacists can contribute to better health and help address unmet needs in the healthcare system. Our next speaker, Dr. DeBittner, will provide further insight into the innovative programs she's working with. Thank you.
Thank you, Anne. Good afternoon. Buenas tardes. It is a pleasure for me to be here with you today presenting at Grand Rounds. Today, I am going to describe to you the Maryland P3 program and highlight its major components and outcomes. We wanted this to serve as an example of the impact that pharmacists and medication management services can have in improving care and reducing overall costs. This program has partnered with the Department of Health and Mental Hygiene in Maryland and also with CDC in the programs for chronic disease prevention and control. The P3 program is what we call an effective solution to patient-centered comprehensive medication therapy management and chronic disease management. We already heard that medications are essential in the management of chronic diseases, making medication management a logical service to address medication adherence and to improve outcomes. The goals of our program are as follows: is to optimize medication use and improve clinical outcome. By doing so, we have been able to see that not only can we improve medication use, but we can decrease medication cost. We have been able to demonstrate that we could reduce unnecessary emergency department visits and hospitalizations, reduce sick days, and really improve adherence and understanding of drug therapy. Patients that are part of this program are better able to manage their medical conditions, and in many cases, even stop taking the medications because they're able to control better their disease. We have assembled a variety of partners in our program that include academic, professional, and governmental agencies. As you can see here in the slide, we have been able to align incentives to a variety of partners to really meet the goals of our program. We have business coalitions that are part, pharmacy organizations, as well as academic and government agencies. By aligning incentives, we're able to engage these partners for maximum impact and potential collaboration among the different entities. I wanted to describe to you the process of care that goes on when patients are part of our program. And as I alluded, we do provide what we call comprehensive medication therapy management. Here, the pharmacists are able to evaluate and assess all the medication regimens of the patient, including over-the-counter and also herbal products. They're able to counsel patients, to assist them with medication adherence, and also to be able to coach them in self-management skills. We do this in collaboration with the team and the patient's primary care provider, and often we communicate with them to identify what are the areas that they want us to emphasize during the encounter with the pharmacist. We are able to produce at each encounter electronic written documentation that is sent to the patient's provider to be part of their medical chart. If we detect that there are any issues that need immediate attention, those are addressed by communicating by phone with the provider, and we're able in many instances to make changes in medications right there, preventing an unnecessary visit to the emergency room, and by so decreasing overall healthcare costs. These encounters with the patients are face-to-face. It could be either at the work site or it could be at the local pharmacy. And on average, we meet with the patient between 5 and 7 times a year. This is at a time that is mutually agreeable with the patient. And the typical length of the initial visit is 60 minutes, and follow-ups are about 30 minutes. I alluded that we do have a documentation system. Our documentation system is called Think EHRX, and this was developed in coordination with our partner, eHealth Objects. This is a technology company that has a lot of experience in electronic health record and also with health information exchanges in various states. By doing so, again, we're able to create tools that are provided to patients and to caregivers, such as medication action plans, personal medication records, and appointment calendars. One of the things that we're exploring is linking our system to Maryland's Health Information Exchange to allow primary care providers to be able to have access to the information that is input from the pharmacist, as well as having the pharmacists have access to data that is in exchange of hospitalizations, ER visits, and lab data. Our program started in 2006, and as of today, we really have focused with self-insured employers, as you see listed here, and we are in a variety of states where we're providing these services. We utilize a network of pharmacists. These pharmacists could be pharmacists that work in independent pharmacies, in chain pharmacies, or in many cases, we also have consultant pharmacists that are part of our program. They are trained in a process of care, they're trained in the documentation system, and one of the things that we find is that we really provide what we call an unbiased, evidence-based care. By being a program that is led by an academic center, we find that there's a lot of satisfaction from the participant and from the employers because they see that our program is not really tied directly to the employers or it's a business, but it's really something that is led with evidence-based by an academic center. So we do have a pretty high satisfaction with the program. We have been able to show a significant track record of improvement in clinical indicators. We've been able to show that we are able to reduce overall healthcare costs once the program is implemented. And we've been able to demonstrate, again, as I stated, that there's high satisfaction, not only from the employer, but also from the employee and their dependents. And in the next set of slides, I'm going to share with you some of this clinical data, and I'm also going to share with you some of the economic data that we've been able to see in the program. We compare our program as we look at the impact that we have in clinical indicators by using the national HEDIS rates. So there are already benchmarks that illustrate what the control for certain indicators should be. So what we do is, you see here the P3 program is in black, and we compare ourselves to commercial plans. So we've been able to benchmark our program against Maryland HEDIS commercial, as well as national HEDIS commercial. And in A1C control, blood pressure control, and LDL, we've been able to demonstrate that the patients in our program achieve a much higher percentage of control in these metrics. This has been sustained year after year, and I have data here from 2012, again, P3 in the black, just to illustrate to you that this has been a consistent and sustainable effect that we have seen in terms of our HEDIS measures. We also monitor a lot of other outcomes of the program. So additional clinical outcomes that we have observed is a reduction in medication-related problems. Again, since we're emphasizing medication adherence, we're meeting with the patient on a frequent basis, we've been able to see that for many patients, for example, we reduce episodes of hypoglycemia. We've been able to increase not only medication adherence, but also persistence, and again, provider and patient satisfaction. The economic analysis, what we do is we provide these to our employers. So what we do is we obtain data from third-party administrators and from prescription benefit managers. And what we do is we use our patients at their own control. We look at what is the overall cost of that for that employer or that particular patient 12 months prior to the implementation of the program and 12 months after. And consistently, we've been able to demonstrate that we do decrease overall healthcare costs even when the employer is paying for the cost of the program. One of the things that employees get as an incentive to participate in our program is that we waive copays, so the medications for the conditions that we're treating and the supplies. So even when we account for the increased cost to the employer or the waived copays, even when we account for the cost of the program, we're able to demonstrate that there's an overall decrease in overall healthcare costs for that particular employer. This cost is estimated to be about $1,000 per patient per year across the employers and the patient population that we have. But we do have one particular employer that is a school system where, again, they have been able to see even higher decreases in healthcare costs. For example, they observe a $2,451 per patient. And one of the interesting things that we saw in this analysis of this subgroup is a 33% reduction in hospitalizations in the cohort that was enrolled in the program. We were able to see that when they calculated for increased and improved productivity, they actually saved an additional $1,047 per employee in increased productivity. We're tracking sick days in this population, and this data has been a little bit more variable. We observed that in certain years, the P3 group had a decrease in sick days, but in other years, we actually observed an increase. So we're in the process of doing more analysis of this data to see what are the factors that are influencing the variability in the data. Because of what we've seen with these self-insured employers and seeing what's going on in the healthcare system, we're actually evolving our model to really enhance it, to be able to fulfill a need in transition of care. So we're working with health systems within our own university to be able to expand the scope of our services to provide a more continuity of care, and also achieve a reduction in readmissions. We're incorporating not only the face-to-face interactions, but we're also incorporating phone follow-ups and also the use of telehealth. In summary, I presented to you an academic-led partnership that's been able to demonstrate not only improving health outcomes, but also a reduction in overall healthcare costs. We provide comprehensive medication therapy management as part of team care, working with the patient's physician, and we've been able to yield benefits not only to the patients in terms of improved health, but to other healthcare providers by increasing communication, the employer and the insurers. And again, we're expanding to make this in a more broader program to decrease readmissions and improve continuity of care. Our next speaker is Dr. Lori Hall.
Thank you, Magali. I'm Lori Hall, and I'm one of about 30 pharmacists at the CDC, and it's my pleasure to talk with you today about why including pharmacists in team-based care is important, some tools that CDC has developed to help incorporate pharmacists, and some examples of what is working in public health. The Community Preventive Services Task Force updated a systematic review of the effectiveness of team-based care for blood pressure control by reviewing 52 studies that used a team-based approach, primarily with nurses and pharmacists working in collaboration with primary care providers, patients, and other professionals. Based on strong evidence, the task force recommends team-based care to improve blood pressure control. In addition to improvements in blood pressure outcomes, team-based care was effective in improving other cardiovascular risk factors, including diabetes and cholesterol. In addition, an independent community guide review of the economic evidence indicates that team-based care for blood pressure control is cost-effective. Implementing this type of multidisciplinary team-based approach requires that organizational changes occur within the healthcare system. These data represent the absolute percentage point increase in the proportion of patients achieving blood pressure control, as well as the reduction of systolic and diastolic blood pressure. Including another team member in patient care improved patients' blood pressure control. And for teams that included pharmacists, the median improvement in the proportion of patients with controlled blood pressure was considerably higher than the overall median increase. Medication management roles for team members differed across studies in 3 ways. Team members could provide adherence support and hypertension-related information with no direct influence on medication prescribing. However, the effectiveness of team-based care was greater when team members could change hypertensive medications independent of the primary care provider or after the provider's approval or consultation. You've heard that collaborative practice agreements, or CPAs, are formal agreements established between a licensed provider and a pharmacist. Following a January 2012 consortium of thought leaders, CDC, in partnership with the American Pharmacists Association Foundation, produced a set of tools to support the implementation of CPAs, which are a critical factor in facilitating team-based care between physicians and pharmacists. These tools customize a core set of 7 recommendations for 4 different audiences with stake in implementing CPAs. These are pharmacists, other healthcare providers, payers, and decision makers, such as legislators or healthcare system administrators. CDC fused the recommendations with case studies about successful integration of CPAs. These 7 key principles are to embed pharmacist services and CPAs into patient care infrastructures, that simple, understandable, and empowering language is best when referring to these services, and that healthcare providers who would enter into collaborative practice agreements should define the details of each agreement, and to make best use of staff skills, scope of practice laws, educational curricula, and operational policies should be reviewed to create synergy and promote collaboration. Additional principles are to pay for the quality of care services based on meaningful process and outcome measures, provide incentives and support for the adoption of electronic health records and the use of technology in pharmacy care, and maintain strong, trusting relationships among patients, doctors, and other providers, and encourage those individuals to promote pharmacist services. These can be accomplished by using the simplified framework you see here. Align the incentives, improve the outcomes, control the costs. In 2012, CDC's National Center for Chronic Disease Prevention and Health Promotion issued a program guide for public health, explaining how to partner with pharmacists to prevent and control chronic diseases. This guide has been a critical element in connecting state health departments with state pharmacist organizations and schools of pharmacy, key partners in rallying health system and community pharmacists. The guide lays out basic information and definitions about pharmacy practice that public health partners need to understand. One of the key points conveyed in this guide is that the role of the pharmacist is expanded beyond just dispensing medications and is evolving into active participation in chronic disease management as part of a team-based care system. It points state health departments to some successful models of practice, such as the Asheville Project, where pharmacists improve the clinical outcomes of people with diabetes employed by the city of Asheville, North Carolina, and reduce their overall healthcare costs, as well as the Diabetes 10 City Challenge and other state-supported programs. CDC is investing in pharmacist-based interventions. One way is through the funding opportunity announcement released in 2013 for all 50 states and the District of Columbia, which outlines an approach to managing, preventing, and reducing the risk factors associated with diabetes, heart disease, and obesity, and to promote school health. This 5-year project supports implementation of cross-cutting approaches statewide and specifically names pharmacists as part of 2 of the intended strategies for state health departments to consider, one of which is to increase the engagement of non-physician team members in hypertension and diabetes management in healthcare systems, and the other targets community pharmacies, who can bridge the community and clinical linkage by building and scaling programs where they provide medication and self-management education. During last month's public health grand rounds, you heard about progress made thus far through the Million Hearts campaign. Team Up, Pressure Down is the pharmacy outreach project of Million Hearts and offers time-saving resources to support pharmacists who are managing patients with high blood pressure and tips for how to tailor the program for any pharmacy setting. There are 3 basic tiers of involvement, from spreading general awareness to increasing medication adherence to providing blood pressure counseling and tracking their outcomes. These implementation ideas, tools, and resources offered in Team Up, Pressure Down are catered to the tier of participation the pharmacy chooses. In Montana, their Million Hearts program is providing yearly funding for up to 10 communities where pharmacists focus on medication adherence issues among their patients with uncontrolled blood pressure. Recently, a participating pharmacist described it as feeling like we're practicing pharmacy again and not just dealing with insurance companies and trying to survive their continued cuts in reimbursement. Turning to diabetes, the National Diabetes Education Program is a joint effort between NIH and CDC that promotes early diagnosis, improves diabetes management and outcomes, and prevents or delays the onset of type 2 diabetes in the U.S. This effort involves over 200 federal, state, and private sector partners. The PPOD initiative, which stands for Pharmacists, Podiatrists, Optometrists, and Dentists, aims to encourage these supportive health professionals to network and collaborate to manage diabetes. They recently released a toolkit which details each PPOD specialty area and gives each discipline a quick course on the others and their relation to managing diabetes. Many past models have engaged self-insured employer groups that pair pharmacists with patient beneficiaries, leading to a number of positive outcomes you've heard about today. Future expansion of these models relies on finding sustainable methods of reimbursement, recognizing pharmacists as healthcare providers, and promoting pathways for pharmacists to practice in a manner commensurate with their training as the medication experts of the healthcare team. Integration of pharmacists into patient-centered medical homes and accountable care organizations is also important because each of these settings aim to comprehensively manage a patient's care. Additional research is needed to identify and evaluate all of the pharmacist-provided services delivered in these practices. There's also a high need for focused improvement on transitions of care for patients and ensuring medications get properly reconciled upon discharge, especially for patients who are at high risk for rehospitalization. Future research should continue to evaluate the therapeutic and economic effects of medication reconciliation provided by pharmacists. Community pharmacies are convenient and accessible settings in which patients can obtain a whole host of preventative services, from immunizations to disease self-management coaching. You've heard today about models that apply to chronic diseases like diabetes and hypertension, but others span depression, cancer, antimicrobial stewardship, and HIV management and screening. A critical place for pharmacists to make an impact is with our medically underserved areas and in places where major health disparities exist. CDC's Division of HIV/AIDS Prevention recently published results from a pilot of 21 community pharmacies and retail clinics that performed HIV testing and found it to be a feasible model for offering rapid point-of-care testing. Access to health care and HIV-related stigma may prevent some individuals from being tested. CDC seeks to learn whether expanding HIV testing to community pharmacies will provide help with overcoming the obstacles of access to care and stigma for individuals living with and at risk for HIV infection. To summarize what's been covered here today, in order to help achieve more accessible, higher quality care that is more cost-effective, pharmacists will serve increasingly important roles as healthcare providers, care team members, and public health professionals. We're on the right track, and CDC offers many resources to ensure pharmacists go from being underutilized to optimally utilized health professionals. And I'd like to thank everyone for joining our Grand Rounds session today, and at this time invite members of the audience to ask any questions you may have for our panel. We'll take questions from the audience as well as our social media audience. So thank you. We'll go ahead and take questions from social media.
Are pharmacists in a position to intervene if a customer seems to be becoming addicted to prescribing medications? And if yes, how?
Absolutely. You know, pharmacists are at the front lines, as we said, of situations where patients may be taking medications irresponsibly. And we know that the public health epidemic of opioid and other prescription overdoses is profound. Pharmacists have many tools at their disposal, both just their personal recognition of when a patient is overusing prescriptions to contact their provider and alert them to the problem. There's also prescription drug monitoring databases available that pharmacists can track where people may be obtaining their prescriptions, if not at their pharmacy, but other pharmacies, so they can better detect these issues. So certainly pharmacists are able to and do quite often make interventions around that very burdensome issue. We have a question from the audience. Go ahead.
Yes. Is this working? Is this working?
There you go.
You mentioned the increasing complexity of medical care. I think we've had an increase in complexity in the last few months with the Ebola outbreak. I read in the last few days that there was a patient or person who went to one of the urgent care clinics in one of the pharmacies in Braintree, Massachusetts. And I think that reflects the fact that pharmacies, especially the chains, are getting into the business of urgent care. And I guess I have a couple of questions relating to that. One is, how does that relate to the pharmacy part? Is urgent care totally separate, or who oversees urgent care? I imagine the urgent care providers are going to be something like nurse practitioners and physicians. And I think there are many benefits to pharmacy urgent care providers. One is the easy access, less expensive than an emergency room, and people who may be a little embarrassed if they've been exposed, say, to Ebola. They might have a little bit more anonymity in a setting like that. So I think that may be an attractive place for persons who have, for example, come from West Africa or been exposed to patients to come. Is there going to be a provision to, for example, put an isolation room in these urgent care parts of the pharmacy where a suspect who's at high risk? Also, is there going to be screening of patients for their exposure? I know this is probably something that pharmacists have not considered, but I think we're all going to be faced with having to reconfigure how we do medicine in this age of Ebola.
Sure. I think Anne would like to answer that.
I'll take a stab at least part of it. I would say in answer to your question about the connection between the urgent care centers and the pharmacy, what we see really honestly is variability in the marketplace. In some places, it seems like the pharmacists that are working in the pharmacy, which often have private consultation areas themselves, may have a good relationship and a consistent communication back and forth. And in others, it seems like it's not as predominant. So it's variable is the answer to that question. I can't answer whether or not the clinics are considering putting in isolation areas, but I would also remark that a lot of patients present to pharmacists with symptoms that could mimic the beginning stages of Ebola. So it's also very important not only for those urgent care clinics, but also for pharmacists who are working in community pharmacies to be in tune to the symptoms and ask the right questions and refer those patients.
Thank you.
And we have another question from an audience member.
Sure. Thank you. Dan Budnitz, Division of Healthcare Quality Promotion here at CDC. I want to thank the speakers for outlining nicely a case for using clinical pharmacies and clinical pharmacy services to improve public health. outlining some of the tools that are available and some opportunities with the changing healthcare system. Are there ways to measure going forward if more pharmacists are entering this kind of clinical practices, either upon graduation or in the workforce now?
Go ahead. You're Magali.
It's a great question. There are several different surveys that take place on a regular basis, pharmacist workforce surveys, and there is one that's just completing and will be released, I believe, in March. And so it's a topic of significant interest within the pharmacy profession. And from the data that we're seeing, it is increasing. A lot of pharmacists are in mixed positions or melded positions where they may have some distributive functions, but then also clinical responsibilities. We're seeing a lot of that. But yeah, there is a significant effort to track uptake.
Thanks. And we have time for one more question, and this will come from a social media audience.
Are pharmacists responsible for knowing or able to know all drugs a patient has used or is prescribed for possible interactions?
Magali, you want to take that?
As we explain the medication therapy management services, one of the things that is done during that visit is really to get a complete drug history. So part of what we do is making sure that the patients we ask and document every medication they're taking independently, if they get it in that particular pharmacy or they get it someplace else, and also to document all herbal, over-the-counters, all medications that they're taking, and the processes. Once that information is collected, is for the pharmacist to assess if there are drug interactions, if there are any potential for that patient not to be adherent to that medicine, if there's issues with the medical condition they have. So the answer is yes. I mean, if you do go through these processes of medication therapy management, you should be able not only to collect information, but also to assess it and make the appropriate recommendations.
And Commander Lee's perspective may be a little bit different from the federal side of things. Would you like to add any comments to Magali's?
Sure. In our setting, patients come to our setting in the Indian Health Service, and they receive the vast percentage of their care at that facility. And so it does improve that process or the ability to obtain that information because of our system within the system. Again, we do have those patients that are taking those outside medications as well as over-the-counter items. And so within our clinical programs, we do ascertain on every encounter what other medications that a patient is taking, so that way we can identify those drug interactions or other recommendations that we need to make for that patient's care.
Thank you again very much to our speakers. And we'll see our audience live or on the web in 1 month's time for the next Public Health Grand Rounds.